I'm Sandra Eismann, and I'm presenting today with Wendy and Matthew. And without further ado, I'm going to hand over to Wendy.
Thank you. Matthew, are you driving the slides?
I will do.
Thank you very much.
So as Sandra introduced earlier on, this is the second in our series of webinars focusing on the caseload model today, and then later on Thursday we've got the core model. So today's walkthrough will be looking at an overview of the model, and in particular to focus on how the model can be used operationally and as a tool to support wider service and quality improvement. And Wendy will share some of her insights and some examples of using the modelling.
Thanks, Matthew. So what a great audience we have today. I'm a community nurse, so I have felt your pain over the years in terms of trying to work out the demand and capacity in community nursing, and it's very complex, isn't it? But actually this model might be a start in helping to make sense of it all. But a model is only part of the story. So when you're doing any demand and capacity modelling, yes, the tool is useful, but it will only be part of what you need to do and part of sort of the improvement work that you'll be thinking about. So it's always really important, even before you start modelling, to be really sure about what is it you're trying to find out, what are you trying to answer. A model will only be as good as the information that goes in. It won't be able to answer all of your questions, and to get the right people involved. So it's really lovely that we've got some really good people on the call that are clearly leading on demand and capacity, working with the teams. And that's what we would expect. If you work with the teams, you'll get a much better output. And actually having conversations with the right people first before you even start modelling is really important. But as we know in the community, there's lots of sort of information and resources available, talking to your teams, but also your data and your data warehouses and your electronic systems. So there is information for you, and it's about gathering all that you can together before you start your modelling. And have an achievable target, so have something to be working towards. You might find with the caseload model, Matthew and I have spoken about this before, you might want to just model part of your caseload or elements of your caseload, or you might want to do the whole thing, but work in sort of in steps that make sense to you. You don't have to do it all in one go, and come up with a bit of a plan about what's your priority and what are you worried about, and what do you need to do some modelling for. And be a detective. You know, it's about really finding out things, asking questions, and actually when you start modelling, you find out things that you didn't know, and you can go away and ask other questions, and it becomes a really interesting piece of work. Thanks, Matthew. So yes, the challenge of modelling complex pathways and services, there's variation in the way services are set up in the community. And of course, on the sort of surface, it looks like it's very difficult to be able to model those services. But and also the access to data and data quality can be poor. So I don't know what systems you use, but I'm used to using Rio. And, you know, the data warehouse will collect some information, but it will only be as good as the information that I put in as a clinician in terms of when I see patients and what I'm seeing them for. And often there's a mismatch between what the data is telling us in a sort of data warehouse and what's actually happening on the ground. And I expect you've had many experiences where somebody has said, it looks like your activity is this, and you go, well, that's not what it's like at all. But even in community services, there are patterns to the way that we all work across the country. You know, patients are generally referred, and there'll be some sort of triage, and then there'll be an assessment or a first visit or a first phone call. So they generally follow a similar pattern, and that's all that modelling needs really, is some form of pattern. We've introduced a starter model. Sorry, the dog is joining in. We've introduced a starter model because we found that in community services particularly, and myself included, our knowledge of demand and capacity modelling is not at the level maybe you see in hospitals because of the data and because of the challenges that there are in the community. So we've developed a sort of a light version that can be done by anybody in teams, and is a really good starter. So you're welcome to use that as well. Thanks, Matthew. So, what can be achieved by modelling? Well, really improved understanding of the service, and that's really important. So for whatever reasons that you're involved in demand and capacity modelling, on the ground, obviously, we want to know that the teams can meet the demand that's coming in and patients are seen when they need to be seen. But it's also about understanding the sort of depth and the breadth of the service, what's being delivered, and whether that's within the commissioning confines or whether actually there are different things happening now and things that change over time. It's a really good exercise to see actually what is the community services delivering now. It can actually help you identify some of your data quality issues and actually help you improve those. We found with modelling across some of the teams I've worked with that actually when you started to look at the demand data or the data in the data warehouse and it doesn't sound right, it's because it's been recorded in an incorrect way, or there are boxes that should have been ticked, etc. And it really does help to improve the data quality, and then as a whole the organisation can see the work that everybody is doing in the teams. And also things like clinical systems with coding as well. I don't know if people are used to things like SNOMED, but things where you can actually gather information about demographics, things where you can gather information about the priority of patients, etc. And it's really important that we use codes and systems so we're able to gain that information as well, and this can help with that. It also helps us with the sort of timeliness in terms of who's on the caseload when they come on and actually when they come off as well, because we do find with community caseloads, and I've been somebody who's done that we may hang on to people because they might pop back on, or we might catch up with them in a month or two. But actually hanging on to patients sometimes means that capacity is used up and new patients then can't access the services. So it's really important that we get to see what does that actually mean for capacity. And also weigh the pathways and processes. Again, it's about really, you're able to really look at what do we do and how do we do things. One of the things that I know is quite a challenge at the moment is things like insulin for patients with diabetes. I know that's become increasingly more difficult to meet that demand in the community as patients are living longer and more patients are given insulin now to manage their diabetes. And it's about understanding actually how can we do that differently, and are there other roles and responsibilities that we could look at with that. And also it reduces that disparity between the recorded data and the clinical knowledge. You actually start to look at an active caseload and actually what is the team doing, and you're able, it saves you time in the long run in terms of having to justify what you're doing and why you're so busy, because actually the information will be held and you'll be able to access it really quickly. And of course, like with anything, evidence to support change. If you do need to make a change in terms of your service design or your workforce, then actually this does provide you with some really good evidence around that. Thanks, Matthew. So the caseload model, as Sandra said, is designed for patients that actually come on to a service and stay there for some time. It's aimed at community physical and mental health services, long-term condition services, so it could be specialist services and Parkinson's, and it's really for pathways where patients have multiple points of contact, and it doesn't need to be the same person, but multiple points of contact by people in the team. And it's applicable to a range of services. It's a flexible model based on patient grouping. So Matthew and I have spoken about it. Actually, it could work across teams. So you could have patients that move across teams, and you could actually model all of the demand and capacity for all of those teams as well. So it's not just for one team. And it'll tell you if you have the capacity to meet the demand and whether waiting list is in a sort of sustainable range, because we know that some patients do wait, and that's absolutely the right thing to do in order for us to prioritise the patients with the most need. So waiting lists can be managed in a more visual way as well, and you can see if they're creeping up or if there are concerns. And it will consider the triage, the assessment, the treatment, the reviews and the reassessment, and all those points of contact along the pathways. It also can incorporate whether you're doing those face-to-face and whether they're virtual or whether they're in groups. And also the skill mix and competencies can be added to that as well. Thanks, Matthew. So just in terms of impact and feedback, there are some improvement wins with demand and capacity modelling. As we say, it provides really good evidence to support improvement. and evidence to inform changes in skill mix, which is really key, I think, for the community as we're modernising and as we're looking at different roles and as we've got lots more senior clinical decision making. It's a really good model to help with that. And it'll help you visualise your demand as well, and visualising the demand in all of the different areas. And I know that patients don't have one condition, and I know that some patients will have a number of interventions across different pathways, but it does help for you to be able to maybe articulate the impact of the rising demand in diabetes management, etc. And it does help with that. Also, you can sort of test scenarios on there about potential changes in service delivery, and all the models that the team produce allow you to actually put in sort of data that's different. So you could actually say, well, what if things increased, or what if the skill mix changed? And you can actually see what that impact that has as well. And also it helps us understand the impact of non-patient facing time. We talk a lot about sort of whole time equivalents available in services, don't we, when we're setting up business cases, but actually it's about the patient facing time that we need to measure, because there's a lot of your time or clinicians' time that is used for very important and patient relevant activities, but not actually available for patients as individuals, like handovers and MDTs. So hopefully that's helpful. Thanks, Matthew.
Thanks, Wendy. So a little bit of background really around the caseload model. The model has been developed essentially to help organisations operationally plan capacity, and has been developed with input and testing from a range of stakeholders. Community and mental health services were our focus in our initial development and testing. However, it's become very apparent that the model's applicable really to any service where we're looking at groupings of patients as the basis of the modelling, and these groupings might well include caseloads as we've defined the model, but could be clusters, could be geographic localities, pathways, teams within a service, different treatments or interventions, or any other really defined patient group. And because the model's flexible and adaptable, you can use your local scoping to determine the most appropriate option. Thinking back to one of Wendy's earlier comments about scoping initially, in terms of what you're wanting to answer from the modelling, gives you the kind of the start point really in terms of what that grouping is likely to be as part of your initial setup. So just a little bit more about some of the patient grouping options, some of those that we've seen so far, and that we've seen some of our initial stakeholders using when we were developing the model. Are those groupings defined by clinical criteria such as clusters or IAP steps in a mental health pathway? Frequencies of contact with the service, so a particular podiatry service created their groupings based on the frequency of contact. Different types of contact with the service, so individual sessions, group sessions, virtual appointments, and treatment schedules such as chemotherapy regimens, or within community nursing. When Wendy mentioned insulin, we've also seen some community nursing teams focusing on wound care, for example. And some of the services that we've seen using the caseload model, and these include sort of allied health professionals, some of the children's services, community mental health teams, community nursing, a number of continence services, dietetics, some musculoskeletal pathways, and also some other psychological therapy services. So quite a broad range there, and quite different approaches in some cases. Just to give some examples and some views of the model, I'm going to use an example from a dietetic service that we've worked with. And the model, for those of you that haven't seen it, is an Excel-based tool. I'm going to show just a few images covering some of the inputs and some of the outputs from the model. The model is available to download from the Demand and Capacity Future NHS workspace, and there's also a recording from a previous walkthrough that you can view as well if you want some further information. So this image shows the setup page for the service, and you can choose to enter the demand data on a weekly or a monthly basis. This might be dictated by the availability of the data or the data quality that you've got available. And with some of our early scoping, some of the services indicated that being able to collect data on a monthly basis was going to be easier than a weekly basis. So there's the option there. You can then specify your different patient groupings here. And in this case, we've got the caseload selected. You'll see also here that there's 11 caseloads selected. The model gives the option to select from 1 up to 15 different caseloads or patient groupings. So then we move on to configure the service setup. And this is essentially how the service is delivered within the caseload or the patient groupings that you want to model. In this case, you can see the 5 different caseloads out of the 11 that I'm shown on the screen, just because otherwise if I to try and fit all 11 in, it would be quite tiny and wouldn't really view very well. But what we can see here is that in each of the caseloads, there's the option to include up to 5 further levels of granularity within the model, and that might be treatment, interventions, types of contact within each of those caseloads. And as you can see here, this might include your new appointments, follow-up appointments, gives you the option to differentiate between any virtual contacts or group sessions that you might be running. And it really is flexible at this point to allow you to configure how your service is actually being delivered. So this is where we then identify the amount of resource required. So for those elements of the caseload, how long do you think on average it will take to provide those new appointments, those follow-up appointments, and what's the frequency of those appointments? Is it on a monthly basis, a daily basis, a weekly basis? The options are there to select all of those, or to put in a different frequency option if so needed. Then within the model, we go on to identify and understand your capacity that you've got available to provide the service. And this can be configured at an individual clinician level, by band of clinicians within a service, clinic or setting. Again, it's purely configurable based on the local service. And you can also identify your core capacity compared to any ad hoc capacity, such as bank or agency resource, or potentially individuals being deployed into a service. There's the options are there to set that up however you identify that works best for your service. And we're looking then at those resources, those clinicians, across which of the caseloads and interventions do they provide support, clinical support to, and how much time per week is provided on each of those levels. The model does allow you to go to a lower level of granularity to start to consider competencies or skills required to deliver specific interventions or specific parts of a pathway of care. So if there are only a certain number of clinicians that can carry out a triage or an assessment, then we can identify that within the model as well and start to look at the demand versus capacity balance in those cases. So just to look then at some of the outputs from the model, and in this case we'll look at capacity, and here we can see the required capacity compared to the available capacity within the service. The required capacity is represented by the orange blocks, and the available capacity by the cross and the red dash. The cross represents the available core capacity within the service, and the red dash any ad hoc capacity. So this enables you to identify where there are any gaps in capacity or where there's any particular surplus. And I've highlighted two of the subspecialties within the service here, in particular, just with the red circles, pediatrics and then general outpatients. And you can see that there's a real variance there between the new appointments compared to the follow-up in terms of the required capacity and available capacity, where there's not enough capacity available to meet the demand for the new appointments, but there is more capacity available for follow-up attendances, which could then be used to investigate further, and some interesting conversations about then the reason that that's currently set up that way, and you might want to look at how the service is being provided in those instances there. And it's quite interesting when you start to get to the lower levels of granularity like this, compared to just looking at a service at a higher level where it might not be quite so apparent where some of these variances exist. So one of the other outputs then is the waiting list. So looking at the estimated sustainable waiting list size compared to the current waiting list size. The estimated sustainable waiting list size here is represented by the orange blocks, and the current waiting list by the crosses. For most of the caseloads here, you can see that the current waiting list size is greater than the estimated sustainable list size. On the previous slide, we saw that the majority of the caseloads did not have sufficient capacity to see new patients, with the exception of the community nursing and the outpatient part of the service. We see here that the community nursing element is showing that the current list size is just under the estimated sustainable list size. So these outputs again will help give you some ideas as to which elements of the service or the pathway you might want to focus on or explore in a bit more detail. And the kind of the what next, the so what, following on from this, it's always important to remember that the demand and capacity work, the modelling is an iterative process. The model outputs obviously help form action plans to encourage discussions and conversations. Thinking back to a few of the points Wendy mentioned earlier on, some of the most important parts of the demand and capacity journey is when you do get people together and you do start to have those conversations about the ways that the service is being delivered, and why it's being delivered in that way, and exploring some of those items here, and very much lead towards identifying some of your service change or improvements. And you can see here that it is very much an ongoing process that supports your improvement cycle, very much about evaluation and learning, and using that PDSA cycle for improvement. And after you've made some changes or implemented some actions, about then rerunning the models and looking at what the impact has been. And so just then looking at the models that are available in terms of part of a suite of tools. The caseload model is one of those tools that are available that cover a range of different service delivery requirements, from the urgent response and ED models for those services requiring forecasting and prediction covering a period of hours, through to the caseload model that we've looked at today and the core model, which you'll be able to hear more about in the webinar on Thursday if you're joining us for that one, or watch the recording of it afterwards. Both of which that focus on a longer forecast through to looking at the service requirements to meet that capacity and demand over a longer period of time, through to the systems dynamics approach for system modeling and system change, which obviously are much more dependent on more interventions across a system, and the time for making some of those changes and implementing some of that work is obviously far longer. So if you want to find out any more information, you can access a copy of the caseload model and a previous walkthrough recording on our Future NHS site, and the recording of this session will be available on the Future NHS platform as well. We do have a range of different case studies illustrating how demand and capacity modelling and methodologies have been used across a range of services, a range of organisations, focusing on kind of the impact, the learning and the benefits of using the models, and we are adding to those continually. So that's probably a good point to pause and see if we've got any questions.
Before we stop the recording, can I get a question in, which is for Wendy, for you and Matthew? So I know a couple of people said they joined because they just want to see, can they use the model? So let's say colleagues on the call, they look at this and go, yeah, I want to know, want to explore a bit more. Where do you start? What's your top tip? Maybe if I can come to you first, Wendy.
Start with a discussion with the team. That's the top tip. You know, get everyone together, talk about what demand and capacity means and how important it is for the team. And also, I think one of the key things is that any modelling is owned by the team. So it's not seen to be something that's done to the team. It's the team actually doing their own demand and capacity modelling with colleagues. So you might want somebody from your business intelligence. If it's not necessary, you can have whoever you feel is appropriate, but get a group together and start talking about demand and capacity and why it's important you do this modelling and what is it that you're trying to find out.
Thank you, Wendy. Matthew.
Yeah, I mean, Wendy covered a lot of things with that answer, but I think that the last one is probably the one I would highlight on in terms of what's it you're actually trying to find out. What's the question that you're trying to answer with the modelling that you're looking at undertaking? I think it's really important to try and hone in on that question, because I think before we even started the recording today, and frequently when we have conversations about modelling, sometimes the ask can be so vast, it can be quite daunting to actually get started. So if you can isolate that to something quite specific, or you can narrow it down to something that you can work on to get started with. You can always broaden it, you can always make it more granular, you can always expand the breadth of it, but I think start simple if you can.
Yeah, thank you very much. And if I might just add something, I think it's similar to what Wendy said and Matthew, but I would almost suggest find a friend. So if your background is in operations, find a friend who works in analytics, who has an analytical mindset. And if you work in analytics, find a friend in the service with an operational background, because the operational colleagues, they can actually describe how the service works in reality. and the friend from analytics can help you actually to navigate the Excel spreadsheet and the actual demand and capacity tool, because that may not be, you might not be a big fan of Excel, which I can understand. So we've seen those collaborations work really well in trusts. And the other thing, bearing in mind what Matthew just said, I would say have a look at the video of the caseload model, because demand and capacity is a very specific lens that we are applying, and you could start very big. But actually, if you look at the model and look at what are the data requirements, I think it gives you a better sense of what you're actually modeling and what you then can do with the output. Can I maybe just finish with the final slides, and then we'll stop the recording and we'll go to more open to questions, comments, or whether anybody would like to add anything. And just to say, we have a number of online resources. Do have a look at our patient videos. We've recorded them. There's You, who tells you a story about the impact it has had on his life to access the right service, and also the story about Elaine, and she tells you about the impact on her life, what it means for her to actually wait for a service. She's on the waiting list for hip surgery. And finally, just to say, have a look if you want to learn a bit more. Look at our online training. Sign up to our demand and capacity bulletin. Whenever we publish new training opportunities or new, we publish anything new, we will announce it in the bulletin. And please do stay in touch with us. And I was hoping, either, as I said, look on the website, sign up to our bulletin, join our Future NHS website, or do follow us on Twitter.